Today we're doing Thriving with Parkinson's Disease with our friends Amneal, and this is a foundational program. We're going to be covering what to expect, how to advocate for yourself for your best treatments. And I know you've heard this from us before, but PMD Alliance feels very strongly that you understand all of the things about your disease and all of your treatment options available to you, and how to have informed conversations with your healthcare providers. And that is why we have programs like this. And while some of you might be dealing with Parkinson's for several years, I know that you're going to learn some nuggets today. For those of you who are new to this journey, this is a great program to give you some foundational information on understanding your symptoms, your management, and communication. So welcome, welcome. Yes, I mentioned this is a program we're doing in partnership with Amneal, but it is, as you can see, being recorded. And we do want you to ask your questions, because unlike the majority of our programs where we kind of hold them until the end, there are very specific points where we're going to pause a few moments and allow you to ask your questions. So I'll be watching for your questions in the chat, and then when we get to that point, we will ask Dr. Soileau of our questions. And before we get too far in, I want to introduce Lucy Fernandez. She is with Amneal, and I'm going to hand this over to her because I think she has some intros.
Thank you so much, Anissa. And hi, everyone. It is so good to see all of your smiling faces and your waves. It's really nice to meet you. As Anissa said, my name is Lucy, and I work at Amneal Pharmaceuticals. And we are so thrilled to do this educational program for all of you today. We have a fantastic speaker, Dr. Soileau, who has joined us and will be delivering this presentation all about how you can truly thrive with Parkinson's disease. And Dr. Soileau is the founder of Texas Movement Disorder Specialists. And what makes him and his whole team really so special, in our opinion, is how much they care about the multidisciplinary approach to treating Parkinson's, and really looking at the holistic journey with PD. So there could not be a better person today to speak with us about thriving with Parkinson's than Dr. Soileau. So Dr. Soileau, I'll turn it over to you to introduce yourself, and then we can get started.
Thank you, Lucy and Anissa and PMDA, and hi, everyone. It's good to see you again, and hope that you're having an excellent week. And I see some of you are just as hot as I am in Austin, Texas. So like Lucy said, my name is Michael Soileau. I'm a movement disorder specialist in Georgetown, Texas, which is just north of Austin. And I'm an owner and faculty member where I teach patients, residents, medical students, anyone who will listen, all about Parkinson's disease and other movement disorders. We do clinical trials at our site. And one of my favorite things to do are things just like this, and partnering with the PMDA, because I feel like I spend most of my time actually explaining some of the things that we'll talk about today. And I am very blessed because I get to see the light bulbs go off with many of our patients once we start talking about the vocabulary of Parkinson's and all kinds of pearls with Parkinson's treatment. And I get to see the light bulbs go off. And so I hope that some points that we talk about today will help you and your team, your family, your caregivers, whoever's listening. I hope that you'll get a lot out of today's talk. So let me share my slides here, and hopefully you can see those and get set up here. Okay, perfect. All right. Okay, so by all means, let's get started. So like Lucy said, we're going to talk about thriving with Parkinson's disease and what to expect and how you can advocate for your best treatment options. So a couple of disclaimer slides. Like we always do. So remember, this information I talk to you about today is for educational purposes only. I have not had the pleasure to examine you or be your doctor in most cases. And so make sure that anything you talk about today. If you have very detailed, specific questions about your Parkinson's or your treatment, I would hope that you have a really good rapport with your healthcare team and that you can talk to them in depth about this stuff and ask them questions and get into the nitty gritty with them, because we're going to make you armed with all kinds of information today to help make that conversation go more smoothly. And then Amneal also acknowledges that while all participants may have agreed to safeguard any confidential or personal information disclosed, neither Amneal or its vendors can guarantee compliance from all participants. So you can see the rest of the disclosures there on the screen. And then one more disclosure slide. So remember, again, educational program will feature information about Parkinson's disease from myself, a healthcare provider, and it's not intended to provide medical advice or care to you specifically, but just speaking in general. And we encourage you to speak with your own team. And out of consideration for our time and my time, I have been compensated by Amneal as I'm missing clinic. So let's get started. So this is an introduction. So first of all, I know many of you know this already. I'm preaching to the choir, but what is Parkinson's? Well, it is the fastest growing neurological disorder. And turns out it's very costly when patients go into the hospital. It's very costly in terms of treatment. So it's got everyone's attention, not just you as the patient or caregiver, but also the federal government in the United States. Parkinson's is a very important chronic condition that is important to treat because it impacts millions of people and costs a whole lot of money to treat Parkinson's. And by 2037, 1.64 million people in the US will have Parkinson's disease. And that's probably underestimated, I would say. And the disease is characterized by a loss of dopamine producing cells in the brain. So I always like to just explain things to my patients in analogies. And so dopamine, my analogy for that is gas in a gas tank. So the whole job of me and my team is to make sure that when we're treating Parkinson's, that gas tanks are full and that everyone has just enough gas to get through their day, to do all the things that they love to do, that they want to do, whether that be go to baseball games or play pickleball, or even more simply, just to cook a meal or write or knit or sew, whatever it is that you enjoy doing in your day in and day out. Our goal is to make sure that you're on the treatment you need to make sure that you have a full tank of gas. So what happens in Parkinson's is that gas is not produced with time, and it starts going down very slowly with time. So guess how we treat Parkinson's? You could imagine we supplement that back to you. And so if you think of it in terms of that analogy, everything we do, every medicine we give, every treatment we do is aimed at making sure that we keep your gas tank full and consistent. The other battle in Parkinson's disease is understanding what you're up against and how to recognize symptoms. And I know that seems so obvious for many, but turns out it's not always obvious. And we'll get into that and give you some clues as to how you can be helped further recognize the symptoms of Parkinson's, because it not only affects the way we move, those are called motor symptoms, but it also affects other things. It's a chronic multi-system condition. So it affects a number of other parts of our body, like our mind and our bowels and our gut and our mood and our sleep and all kinds of stuff. And again, we'll get into that. And the blessing there is each and everything has treatments. So that's very important to recognize. So let's talk about the who, the what, and the why. So first of all, who gets PD and why? Well, more men are diagnosed with PD than women. Sorry, guys. The age of PD can vary, but the average is about 60 years old. So my youngest patient with Parkinson's is about 23. So, and then I certainly have 90-plus-year-olds with Parkinson's. So again, we can see the full spectrum of ages there, but on average, it's about 60 years old. And then you already heard some stats about how common it is, but 1% of the population over 60 of age will have Parkinson's. Genetics plays a role, no doubt. But clear as day, there are many people who do not have a genetic predisposition for Parkinson's, yet they still get it. And then exposure to different environmental toxins have been very hot on the press and in the news. But yet there are plenty of folks that have never been exposed to a particular substance and still have Parkinson's. So guess what? The reality is we don't know exactly what causes Parkinson's disease, but we are closer now than we've ever been, I'll say, as to identifying some of the correlations with Parkinson's. But that is one thing I would caution folks on. Social media has become very popular these days as a source of information. And we've had many patients of ours ask very good questions about videos or subjects or news articles they've seen on social media. And just remember to vet those things with your healthcare team so that they can help give you a good idea of what the likelihood of that video or that information is at causing Parkinson's, because there's a lot of misinformation out there that we have to make sure that we kind of vet and critically appraise, right? Anytime we see something on the internet, as the old saying goes. And then lastly, sometimes repetitive head injuries can cause Parkinsonism. So there are a number of different factors that you could imagine play a role in Parkinson's disease, and how everything works together is what scientists and researchers are really looking at, so that we can get to the bottom of that and hopefully stop Parkinson's. That's the goal for all of us. So again, you heard me say that Parkinson's is caused by an abnormal protein that builds up in the brain and causes dopamine to not be produced. And so with time, very slowly with time, dopamine or that chemical that helps us to move starts to go down with time. And if we give you back your dopamine or refill your gas tank, you can see there that's how we treat Parkinson's for the most part. However, the brain produces insufficient dopamine, causing body movements to become abnormal. So if you think of a brake pedal being pressed too much, that is exactly what happens in Parkinson's disease. Our brain is telling us where to go. It tells our legs to move. It tells our voice how to respond. It tells our hands what to do. But yet when we go to do those movements, it's not weakness that's the problem. It's actually a coordination of movement and the inability to do what your brain is telling your feet to do or your hands to do. And so therefore, your walking is impaired and your dexterity may be impaired. And so again, those are the things that we try to fix with Parkinson's and treat. So tremor is something that catches everyone's attention with Parkinson's disease. Most people think of Parkinson's as being a tremor disease, but I'll tell you, not all Parkinson's has tremor. And that's why a lot of people that have the type of Parkinson's that does not have tremor, a lot of times their diagnosis flies under the radar for years and years and years. But everyone with Parkinson's should at least, at the very least, have rigidity or stiffness. But remember, not everyone has tremor. Bradykinesia is a fancy scientific term that just means slow movement. And I don't mean slow like if it's cold outside and it makes it harder for us to get up and move, so we move more slowly. I don't mean that. I mean, we start off in Parkinson's, you may start off doing a movement very well. Your voice may be quite strong. You may be moving your arms or hands, and your dexterity may be great, or your steps may be nice and wide and confident. But the longer you do that movement, then you start to have smaller and smaller and smaller steps, or the movements become more and more and more difficult. And that means that your gas tank is being depleted, your dopamine is going down. And so therefore, that's how we try to treat Parkinson's, by filling that back up again. Some folks will have difficulty speaking too. So oftentimes, one of the things that I hear over and over in my clinic is that patients care partners will often say, we can't hear him or can't hear her when she's talking. And then the other spouse, or the spouse will say, the patient will say, but she can't hear me anyway because she needs hearing aids or something like that. And so we'll go back and forth. They're not speaking loudly, they can't hear anyways. And so we have to work with our families and making sure that the patient with Parkinson's can speak boldly and confidently because they have a loss of dopamine. And then also whoever is listening needs to be able to hear what they're saying as well. And that's a common conversation that we have in our clinic. So from a non-motor symptom, so this is what takes a lot of the time in our clinic with Parkinson's. The treatment of non-motor symptoms is oftentimes what causes the most disability with our patients. So you can see things on there like depression or mood trouble, constipation, trouble with urination, pain. Yes, Parkinson's can cause pain. Sleep disorders, including acting out of dreams, so punching or kicking or running in your sleep. So remember that, and you see the next bullet point, loss of smell. So remember that Parkinson's usually starts with a loss of smell and dream enactment, and that can start 10, 15, 20 years before a person ever has tremor, stiffness, or slowness. So when you wonder when your Parkinson's may have started, it's actually started whenever your smell is gone, or reduced, I should say, or you start acting out your dreams. Because normally in our sleep, we should not be acting out our dreams. I should not punch or kick my spouse if I'm dreaming that something's chasing after me. However, all too often that happens, and that causes the patient to oftentimes sleep in another room so that they don't disturb their spouse, and that's not ideal either. So again, a lot of these things we can address if we ask the right questions. Fatigue is something, though, that we hear all the time. And remember, not everyone with Parkinson's has fatigue, and not everyone with fatigue has Parkinson's. Lots of different things cause fatigue, not to be confused with sleepiness, completely different, right? Slowness of thinking or foggy thinking, feeling anxious or agitated at times and periodically, all these things can be caused by Parkinson's disease and also may be related in some way, shape, or form to dopamine. But we know that Parkinson's is not just a dopamine problem. There are a bunch of chemicals in the brain, neurotransmitters as we call them, that may be altered in their levels. And so again, I feel sometimes like a chemist where I'm trying to get all the levels squared away and find the perfect recipe for each and every patient, because that's what it takes to keep them going. So how do things progress with Parkinson's? So symptoms may begin in small ways. You heard me say loss of smell, dream enactment is a common thing in Parkinson's, and then that can go for years and years, and then maybe they develop some stiffness or slowness. Typically, though, Parkinson's will present with one side being worse than the other. Okay, it could just as easily be a person's left, it could just as easily be their right side. But once your bad side, always your bad side. So whatever side it starts on, that's typically the side that causes the most problems through the years. Tremor can happen mostly at rest, not to be confused with an essential tremor or an action tremor where you go to do something. So something like eating, drinking, pouring, or cutting, using a screwdriver to a screw. However, people with Parkinson's commonly have, if they're holding the newspaper, they may shake, or if they're holding a plate in a buffet line, they may shake. That's a common thing because they're not really moving their hands, they're holding it. And so that's a common time for someone's tremor. And then with time, symptoms do tend to progress. And a lot of times our patients, I probably diagnose 9 or 10 patients a week, new patients a week with Parkinson's. And many times the questions are the exact same. What am I to expect? Now that I know I have this, what do I expect? Well, unfortunately, it does get worse with time, but that's why we do everything we can, and we're aggressive at treating Parkinson's so that we can get a hold of things and make sure that you're living your best life and thriving. Now, there is a saying that we always have, that when you've seen, and you've heard it, I'm sure, but when you've seen one person with Parkinson's, you've seen one person with Parkinson's, right? And that's true. So if we were live, I would always say, look to your left, look to your right, each and every one of you with Parkinson's, would likely have a different dopamine level, a different presentation. You may describe the same symptom quite differently. So it's a lot of fun for me and my team to get to sort through all this stuff, but it also takes some art in how we ask these questions, because we want to, again, we want to talk the same language to you and understand what you're feeling day in and day out. And when those symptoms start to become more noticeable or new ones happen, we have to be aggressive in our treatment options. And again, working with your team to find the right regimen for you. Again, it's all about the recipe. I can't stress that enough. So if you tried a certain treatment or a certain medicine and maybe that didn't work, that means that that's probably not the right one for you. But the blessing here is that we're with tons of treatments for Parkinson's. I've never been more hopeful than I am now because of all the different treatments that we have for Parkinson's disease these days. But that's also the curse of things, right? Rather than the blessing is, yes, we have all these treatments, but then we also have all these treatments. And so we have to figure out which one works for you. All right. So that's a little bit about that. So let's pause and open it up for some questions briefly, if y'all have any. I'll be watching the chat as well, just to see. Folks are still saying hi and where they're from. Hi, Don from Georgetown, Texas.
We do have a couple of questions. So one person had written into me directly. It said, I've had a constant runny nose and it doesn't seem to be allergies and it's not responding to allergy medication. Is this a symptom of Parkinson's and is it related to loss of smell?
Great question. So when we talked about the non-motor features of Parkinson's, there are many, many more that aren't listed there. And that is one common thing in Parkinson's disease is to have a runny nose. Why that is, we have no idea. It certainly is common with Parkinson's. And I always know that that's the case when I see someone with handkerchiefs in their pocket and they keep their handkerchiefs or in their purse perhaps, and they pull it out and just kind of wipe their nose. And I know it's dripping and it can be a very troublesome symptom there. But yes, that is, or it could be from Parkinson's. And then there are treatments that we can always try for that too. Ear, nose, and throat doctors have some things up their sleeve that can help with that. However, that's not to say that everyone with runny noses have Parkinson's either, right? Just like fatigue, a lot of different things could cause that. So yeah, great question.
And we just got another one. What is rigidity versus stiffness? And is being stiff the same as when you yawn and stretch at the same time?
Yeah, I think I know what you're talking about there, yawning and stretching. So stiffness and rigidity are the same. They mean the same, just two different words. There is a difference in a term called spasticity, which is a type of stiffness that gets worse after you move quickly. So for those of you who maybe have had a stroke, or maybe you know someone that's had a stroke and you see that they have some stiffness and they walk around with their arm curled and maybe they kind of have a limping walk to their gait, that is something called spasticity. So you have stiffness there as the brain heals from, for example, a stroke, but it's not quite the same as the stiffness or rigidity that happens in Parkinson's. It's because of where in the nervous system the problem was. So Parkinson's is a very different area of the brain than, let's say, a stroke and where it happened, or let's say a spinal cord injury and where it happened. So they cause different degrees of stiffness. So that's why when someone comes into my office and I say, hey, I noticed you're stiff, there are different things that we do to try to help patients tease or really to help patients understand what type of stiffness they have, because that dictates what treatment I use and what workup I do. And so when you yawn and you stretch real big and you're stretching your arms and legs and then you kind of feel stiff there, I have that too. So that's a little different than Parkinson's stiffness per se. But that's why a good neurological exam is quite important. So we can tease out exactly what the issue is.
And I think I'll do one more question, and then there's a couple, well, one that came in I think would be great for the next section, but this is related to symptom, and it was, I feel this shaking inside of my body, like my organs are vibrating. Is this a tremor?
Yeah, and I can answer that. So that could be one of the motor symptoms of Parkinson's or non-motor symptoms. It could go either way, because we often hear patients with Parkinson's that especially have tremor feel like they have an internal tremor. Your organs aren't actually shaking inside your body, but we certainly do have patients say they feel an internal tremor. And a great example, which we'll get into here shortly, is when your dopamine levels are starting to fall, a person can feel very anxious as well. And you can almost have a panic attack type feeling when dopamine starts to fall. And that can make someone feel very anxious or very jittery too. So that feeling can be both a non-motor feeling related to mood, but it can also be a motor symptom of tremor. So it could be both. Either way, though, we typically treat it very similarly, and we'll get into how we treat that shortly. Great question. And I think what I'll do is I'll keep going. I know there's some other questions that have been sent in. I think some of these that you ask will be answered, but at the end we can always wrap
Yeah,
up.
I'll hold them and then we'll come back to them. I'm keeping track.
Perfect. All right, so let's talk about the infamous on and off time. This is something that we get asked about all the time, and it is confusing, I know. So that's why I'll try to give you my 2 cents about how to recognize that. So what is good on time? Good on time refers to your symptoms and how you feel when your medicine is working well. That is on time. So if it says you may feel almost like you did before your symptoms began, that is my goal. So when I see a patient with Parkinson's, my goal is to treat them so well and to give them the right dose of medicine that their friends and family say, you have Parkinson's? I had no idea, because you're treated that well. That's always our goal. And sometimes we have to work really hard to get there. Tracking exercise and physical activity with the help of a care partner can support symptom management as well. You know, there's some really cool data that came out recently about the importance of exercise in Parkinson's. We've always known exercise is helpful for Parkinson's, but it can really change the way your Parkinson's progresses. And so for those of you who have maybe been very active and faithful at working out, and then for whatever reason you had to stop for a while, and then you felt like your Parkinson's kind of slid a little bit and maybe took a step back, that's why. It's very important for Parkinson's folks to exercise. And then you can work with your doctor and your team on what a good on time is and what that means. So my rule, my 2 cents here is that timing is everything. So I feel like a broken record sometimes in my clinic, because the patients will come in and they'll say, well, I'm complaining of this or this or this or this. And they all are related to each other because they're all dopamine problems. And so my next question is, well, what time does that happen? And they'll say, well, it happens at any time throughout the day. There's no pattern to it. But something funny happens when you write down when you have those symptoms. There actually is usually a pattern to those symptoms. And if it's right after you've taken the dose of your medicine, or maybe it's an hour or 2 after, that could be when your medicine is at its peak. And those could be issues that you have related to too much medicine. Or if it's right before you're due for your next dose, which we'll talk about shortly, that could be issues related to needing more medicine or needing to adjust the timing of your medicine. So the bottom line is, when your body demonstrates something to you, or you feel something, whatever it is, take note of it, because that may be your body's alarm clock saying, hey, I need something. But what that is for you versus someone else with Parkinson's may be completely different. So that's why I always say, pay attention to your body. And as long as you know what to look for, then it makes much more sense. Now, conversely, what is off time? So off time happens when your medicine is not working as it should. So these can be predictable, they can be unpredictable. And, we've always had a habit as doctors at clumping everything together and saying, well, this is all off time. But the reality is off time is different for each and every patient. And it's different sometimes from one moment to the next. For example, sometimes when you take a medicine, you may have a partial on. Your medicine may work a little bit, but not really as well as it does sometimes. Sometimes you can have a dose failure. I'm sure many of you have taken a medicine and expected it to work and help, but it didn't. And then you have to take it again later on, and then it did that time. That's called a dose failure. You took medicine and it didn't help you get back into your on state. Some folks have an early morning off. They wake up, they get out of bed, they have a hard time rolling over, hard time moving, and that's an early morning off. Wearing off is what happens before you're due for your medicine and you have those symptoms of off time. So things are good, and then as soon as you're due for your next dose, maybe those symptoms start creeping back in. That's called wearing off. If that happens pretty close to your next dose, that's great. But if that happens an hour or two before your next dose, that's a problem, because that's time that you don't have good coverage of dopamine or whatever the case may be, whatever treatment you're on. And we've got to make sure that you've got what you need so you can go on about your day. And then probably the biggest thing that steals control or robs control of our patients is an unpredictable off. They're shopping, they're going, to get groceries, and then in the middle of aisle 6, they all of a sudden can't move, and they've got to cut their grocery store trip short because they just can't make it. They have no more dopamine left, and it came out of nowhere, and it's very frustrating. And so again, when a patient complains of these things, I approach each and every one of these symptoms differently based on treatment. So off time can feel, again, like I've alluded already, like a motor problem. So that's the tremors, stiffness, slowness, trouble speaking, trouble with balance, or you could have those anxiety feelings like we talked about, pain, fatigue. Here's one, sweating. So the closest that us guys will ever know what a hot flash feels like is when dopamine levels start to fall. You can get sweaty, just profuse sweating right before that happens. And again, that timing of that is a clue as to how we treat them. And then also foggy thinking. So those are all examples, actually not an all-inclusive list, but those are common examples of off time. So how common is it? Super, super common. Greater than 90% of patients have at least one off episode per day. Greater than 65% of patients experience at least 2 hours of off time per day. I would say in a lot of our studies, the average off time is about 6 hours of off time per day, not 2. And then also greater than 20% experience more than 4 hours of off time per day. So it's true that if we don't ask these questions, we don't get these answers. But a lot of patients don't realize, like if I walk in a room and I say, hey, do you have any off time? You may say, I don't think so. And then if I just kept moving, then that doesn't get treated. But if I reword that question and I say, hey, are there certain things that you don't do because of your Parkinson's disease that you wished you could do? And then they say, well, yeah, I don't sing in the choir anymore because I don't know if I'm going to be able to have a voice that morning or not. So I just decided not to do it. So instead, I'm doing good just to get to church. That's a common example I hear. That's off time, although you may not recognize that, right? So as long as you recognize it's off time, then guess what? It can be treated. So that's why we're talking about this today, is because if you recognize what that means to you, the patient, or to your loved one with Parkinson's, then now we can do something about it. So talk to your healthcare providers, but come to your appointment prepared. Know your medicine. Know your workup that you've had for Parkinson's, and keep a log, write things down. My engineering patients will give me 150 data entries in an Excel spreadsheet on their off time. That's a common engineer thing, which I always think is so funny. But take a log, pay attention to your body and its alarm clock, because your body will tell you what it needs. We just have to recognize it and listen to it. All right, so that's a good place for us to stop and talk about off and on time, answer any questions there related to that.
Okay, so this person wants to know, should you go to your appointment to see your doctor off? My husband always seems to do better for the doctor than what I see at home. I'm worried the doctor's not getting a full understanding.
We get that question all the time, and the spouse is always like, wow, he's always showing off when he's walking in front of you, Dr. Soileau. Don't worry. Actually, I don't mind that. I love that, because then once they show off, then I can say, oh, so you can do that. So let's do that more often, right? And your doctor may have different reasons for wanting you to come on or off. In my clinic, I don't need to have my patients be off their medicine by the time they see me, because there are other clues I look for and other questions that I ask that help us to determine how well you're doing. But again, the most important person is you and your care partner, who tell me how you're doing day in and day out, because you're right. Whenever we see our patients, it's a snapshot in time. So talk to your doctor and healthcare team, see what they want from you. But at least in my clinic, I don't typically have my patients come in the off state unless we're doing something very specific.
And then I know we didn't talk too much about this yet, but this person wanted to know about dyskinesia. So they want to know if they get more dyskinetic actually when they start to wear off or seeming to, as well as being on. And is that something that is common, or something else like going on as far as the management of the meds?
That's an excellent question. If it's okay, I'll hold that question, because I know that we're going to get to that. And I'm going to show you a picture that may make it make a lot of sense. So, keep me honest. Don't let me forget about it, but I will answer that question here shortly.
Well, I know you're getting ready to talk about the medications, how they work. So some of the questions that's come in are related to that. So I will hold those and we can come back to those.
Perfect. That's a good segue. So let's talk about the nitty-gritty of Parkinson's medicines. So how does levodopa work for Parkinson's? Remember, levodopa is one of our oldest medicines that we have for Parkinson's, been around for 50 plus years, and we still use it today. Unfortunately, there are still lots of myths around levodopa and when to start it. And a lot of our patients are very fearful of starting levodopa, because they're worried if they take it now, will they still get to use it later on? Or will it still work in their system later on? And we used to not know the answer to that question. Now we do. We know that levodopa never stops working in the brain. As long as the brain can see it, that's the most important thing, and it will work forevermore. The challenge is that GI absorption, and in other words, absorption of your medicine in your gut, diminishes with time. Your dopamine's diminishing with time, so it becomes more challenging for us to keep it efficient. And that's why we work so hard, and that's why there's so many new developments of medicine for Parkinson's, is how can we get this medicine, this treatment to your brain more efficiently or conveniently. And so again, just want to say a blurb about that, because even in 2023, despite knowing about this phenomenon for years, we still have a lot of patients who are very reluctant to start medicine for their Parkinson's out of fear, and because they've read it on the internet. And so I just want to make sure that you know the latest data behind that and the latest thinking behind that. So what you see on the screen there is a neuron. That's a nerve cell. And what dopamine or levodopa does is it goes to your brain eventually after it's absorbed, and it helps your brain produce dopamine. And then that dopamine works on receptors, and that's how you can actually do things after you take levodopa. There are a variety of other medicines, though, that work at some way, shape, or form of the nerve cell, the neuron. So that's part of the amazing science behind medicine and Parkinson's, is so that we can try to find unique ways to give and deliver treatment options to patients with Parkinson's. So if you take one of your medicines, let's say levodopa, and you take it, by the time it gets absorbed, your medicine or your gas tank will go up and it will be full. But then after about 4 to 5 hours, it starts to come down. That's why timing is very important. So when patients are taking their medicine and they're taking it every 8 hours, that timing doesn't make a lot of sense in Parkinson's, because that means if it's only lasting 4 to 5 hours to start, that means they're going another 3 hours, 3 or 4 hours even, without good dopamine coverage. So literally just changing the timing of their medicine can make a huge difference. So here's that gas tank analogy again. So when you take your medicine, that blue box that you see is your sweet spot. That's where we're trying to keep your recipe. That's where we want your dopamine. If you didn't have Parkinson's, your brain would keep that dopamine at that level, no matter what we did, what you needed. If you were mowing the grass and you needed a little bit more dopamine, no problem. It'll give it to you and it'll keep it level. But we're having to act on your brain's behalf, right? Because it has Parkinson's. So if you're taking your medicine and you go above your sweet spot, that's when you get dyskinetic or you start moving too much. And I said I would answer that question in a little bit. That is called a peak dose dyskinesia. So that means when you take your medicine after it's fully kicked in and it's at its peak, that's when you may have wiggly movements. There are some patients, though, that have wiggly movements when they are going up on their medicine or down on their medicine. And when they're at their peak, they don't. Those are pretty rare, but certainly we have patients that have those. Again, that's why the timing of your symptoms helps us know how to treat it. Most patients, though, have peak dose dyskinesia, where the medicine's fully kicked in, but it's a little too high and it's above your sweet spot. And so that's when you get dyskinetic, as you see there. Imagine if you're not timing your medicine appropriately and you're taking it every 8 hours, then you're going in a lull way below your sweet spot. And so you're not getting the benefit there. So that's why sometimes the answer is a lower dose, but taken more frequently is the winner. And so it just depends on your Parkinson's and where your dopamine levels are, because I have some patients that need medicine every 2 hours, and that's how narrow and thin their sweet spot is. And then I have some patients who barely need to take anything because they still have some dopamine in the brain that helps them get around. That's why we have to come up with a unique recipe for each patient. So there are options for increasing good on time, and that includes the following. So number one, we can always increase the dose or the frequency of immediate release carbidopa, levodopa. So again, when you're keeping your timing consistent, we can reliably predict what to do with your medicine. If you're not if you're not consistent with taking your medications and you're taking them willy-nilly perhaps and not on a routine basis, it makes it more challenging for us to kind of troubleshoot some of your symptoms. That's why we encourage patients to do their best at keeping on time with their medicine. We can always add medicines that help prevent the breakdown of dopamine. And that's what these next two options, an MAOB inhibitor or a COMT inhibitor, do. So not only can we give you dopamine and keep it there, but now we can prevent the breakdown of dopamine so there's more in the gas tank and it'll last longer. That's what those medicines do. And there are a variety of different options with all of these so far. We can always add medicines called dopamine agonists. Dopamine agonists are older medicines, sometimes with some side effects. I don't use a lot of those medicines anymore because we're so lucky with so many other options, I should say, with less side effects. But a dopamine agonist mimics dopamine. It doesn't become dopamine, but it works at the receptor level. And it mimics dopamine, which can be helpful for some treatments. But what if you're pretty good with a background of your medicine, but then there are these moments that come out of nowhere where you could use a booster Well, we can also add as needed medicines or rescue medicines into the mix. We can also do a combination of any of the above. We can also add longer acting carbidopa levodopa, and there are a variety of medicines that can do that too. I could go on and on and on these days with all these treatment options. And I hope if you don't hear anything else today, I hope you leave this presentation feeling hopeful that there's a variety of different options to treat your symptoms. That's what I hope you leave here knowing. You can see here's a few different releases of carbidopa levodopa. It's the same medicine. I think we're up to like 9 different versions of this medicine now. But how it's prepared, how it's absorbed, how it's taken makes a difference in each and every person with Parkinson's. So we have immediate release medicine, we have controlled release medicine that it's not as potent, but it may get dissolved more slowly. And so it's a little easier on the upswing, if you will. And then we have extended release medicine that, for example, has both immediate release and extended release medicine, the best of both worlds there, where you can kind of get a smoother time from point A to point B. And that can be helpful for many patients too. So that's just an overview so far about treatment, medicine, specific medicines. For the sake of time, I'll just keep going a little bit and then wrap up at the end if that's okay, because I know that we're going to get to some other questions here shortly. Okay, so Dr. Soileau, you just told me there are all these different treatment options. What do I do? What's the next step? This seems overwhelming. That's why it's important for you to have a good team. It takes a village to treat Parkinson's, and that's what we're here for. So you have to pick your battles. You have to pick your goals. You know, let's say that I see a patient in 30 minutes for a return visit. They may come in literally with 15 or 20 things to talk about. I'm not going to be able to get through those 20 things and do it justice. So we may pick the top 3 things, and we may really hone in on those top 3 things, because guess what? Small additions or small changes to your medicine make big differences. So one small adjustment in timing or to a medicine may have a downstream domino effect for the better with your other complaints and your other symptoms. So there is a method to the madness of not addressing each and every 20, bullet point list of symptoms or complaints. We have to have realistic treatment goals. And that's why it's important for you to come in armed and ready to go, knowing your medicines, knowing exactly how you're taking them, have a list. There are a variety of resources that you can look into that help you come to your appointments prepared to talk to your movement disorder team. And I'll also add that 4 ears are better than 2, meaning if your care partners are there, please have them come back, because they will oftentimes see something or observe something that the patient can't feel. And vice versa, the patient will feel things that the care partner can't see. So it's always good to hear both points of view there. And then as time goes on, we are never stagnant with our treatment. We always are aiming to adjust things and move things and a little tweak things here and there, because we want to stay up on your disease. That's why we don't like just twice a year visits. We like to see our patients more frequently than that by our team, so that we can keep up on the symptoms and pick our battles appropriately there. We get asked a lot about diet and nutrition, and really the data points us to just have a healthy, well-balanced diet. There's not been one diet or nutritional supplement that's been shown to be an amazing breakthrough in Parkinson's, although the Mediterranean diet tends to be a pretty good brain and heart healthy diet. But exercise for sure is crucial, like you've already heard me say. And then rest. Remember that if you're acting out your dreams and you are watching TV all night because you can't sleep and you have poor sleep hygiene, that affects everything the next day. And if your sleep-wake cycle gets off, that affects everything the next day. So resting, getting that deep, restful, restorative sleep is crucial in Parkinson's. And again, we have treatments for that too. And as we wrap up here, I'll talk about the concept of dopamine. Some of you may have already heard this. I'm not sure, but you may have heard this, but dopamine is the medicine only you can give yourself. And dopamine is a concept developed by a team of Parkinson's disease researchers and doctors, one of whom was living with Parkinson's. And in their practice and in their lives, they had to come to believe that patients had a strong sense of control, and they felt that they were an active partner in their treatment plan rather than just a patient who sat back and accepted treatment. And if you have a strong sense of control, you could fare better and have a better quality of life despite being diagnosed and with Parkinson's and some of the challenges. It's unfortunate, even unfair, that you're dealing with this problem. So that validates and recognizes that it stinks to have Parkinson's. It's not always rainbows and sunshines. However, you have the power in your hands and in your heart to make the most of your treatment and to play an active role. And the PMDA just prides itself on this, advocating for those with Parkinson's, educating those with Parkinson's. So set goals for your treatment so that you can have good on time, and don't forget to take your dopamine. And that sounds kind of, tongue in cheek, but it's true. When I see patients take an active role in their disease and they're good listeners, okay, and you work collaboratively with that patient, their outcome is night and day different than someone who sits back and dwindles away. So again, I hope that what you've heard today is encouraging to you, and I hope that you leave feeling empowered to do something about it, because that's what we're hoping for. And with that, I'll wrap up and be happy to take your questions. Thank you so much for your attention.
Awesome. Well, and we do have a few more. You turned off your video, so I can't see your face. And I know everybody wants to see your face. So I want to.
Sorry, I don't know how that happened.
I don't know, it just bumping something sometimes. So we just got a comment. They love your dopamine. I love your dopamine also. I think that's fantastic. And speaking of dopamine and dopamine, we had a question earlier that I held on to, wanting to know about exercise, including boxing, helping patients to build strength, but also, can it increase dopamine? We know it helps, but does it increase dopamine?
Yes, it actually can increase dopamine, but it's a double-edged sword. So it can increase dopamine and help Parkinson's. We know that. But if you use up too much of your gas tank, that's why some people, after a strenuous exercise, they may feel kind of pooped after. They may feel like they don't have a lot of energy after that. And that's when some people will actually take a little more of their medicine, or take a little as needed medicine beforehand, and then go do their boxing so that they've got a little more gas in their gas tank. So it's a double-edged sword. It's also more complex than that. There are new chemical compounds that are being discovered, not in humans, but in other animals who have Parkinson's and exercise. So it turns out maybe exercise actually produces some other elements in the body that actually help Parkinson's that's not related to dopamine. We've known that for years. Somebody with Parkinson's exercises, they do great, but then when they, as I said before, whenever they stop exercising, they kind of regress a bit and they feel like their Parkinson's is not as well controlled, or maybe their tremor is a little worse. It's because exercise does more than just keep you healthy. There's something to it. And so we always tell our patients, listen to your body, do exercise, but don't overdo it. Make sure you're listening and paying attention and taking a break when you need to.
So in terms of people being able to keep track of off and on, I have a couple questions around that. So one person wrote, some days are different than others, and sometimes it's hard for them to keep track of that, journal that, or whatever, so they can give their physician a good snapshot. They wanted to know if there are any specific tracking devices or ways to journal that. And then there was another question related to that about, apps such as the Apple Watch for monitoring daily symptoms. Those help. So those go together. So I gave you a 2 for 1.
Yeah, twofer. So yeah, that's exactly right. So it can get tough. And every day is a unique day. So that's why we care mostly about the big picture. So I like to think, if you're able to think in terms of a whole day rather than, 4 hours at a time, that's great. If your days are too difficult though, and they're kind of erratic, then think in terms of a week. So in 7 days, how many of those 7 days do you feel like you're not at your best? And so that'll help you get a gestalt or a big picture overview of how you're doing. And what I like to do, there are some very simple tools online that talk about on time, off time, and give you a place to list your medicine and give you a place to even list when you eat. Because remember, sometimes when we eat, the protein affects the absorption of some of the medicine that we give for Parkinson's. There are digital ways that do that too and make it easy there. And then now there are the wearables that make it or try to make it really easy to not only remember taking your medicine, but also what about tremor? What about dyskinesia? I'll say that they are better now than they've ever been, but there's still a lot of kinks that people are working out, that software engineers are working out. For example, someone who has dyskinesia in the middle of the night on their wearable, we know that that's not actually dyskinesia because you don't have dyskinesia when you sleep. But maybe that's acting out dreams and you're moving from your dream state. That's not dyskinesia. So again, there are some pitfalls to the wearables, but I think they're great tools and they can really help. Don't forget about your care partners. A lot of times they will see it on your face. That's why they ask our patients, did you take your medicine? Because they'll see something that prompts them to say it. So that's why I love the collaborative effort there. We get the points of view from not only the patient, but also the care partner. But do the very best you can. While I think it's great to write all this stuff down, don't get overwhelmed with the homework. Just try to keep it as simple as possible. Do the best you can. You even remotely preparing for the visit is more than a lot of patients do. So I just want to encourage you, try to do your part, but don't get overwhelmed with the details. Just do the best you can. Believe it or not, your movement disorder teams are pretty good about reading between the lines for the most part. And so it just your piece of the puzzle there just adds so much more to the picture. So we appreciate it.
And I think we have time for one more question. And we've had a couple of people want to know how often should they be seeing their movement disorder specialist? Is there a specific plan that they should be following?
Yeah, I see tons of questions about that. So I would not say there's a specific plan. However, my practice is hopefully that you're seeing somebody in our clinic at least every 3 months. I can't possibly answer every phone call by myself or see patients all the time, every 1 month or 2 months, because we're pretty lucky in the state of Texas, at least in my region. We still have 5 movement disorder specialists in our region. However, that serves about 6 to 7 million people. So there aren't nearly enough movement disorder specialists for us to see patients as often as we would want to. That's why it takes a village, right? So as long as you're in the movement disorder clinic, my rule of thumb is that if you're seeing someone every 3 months or so, that's a pretty good rule of thumb. Unless you consistently go to your doctor and they say, well, nothing, you're doing great, nothing to offer, doing well, broken record, then that means maybe you can get by with twice a year. But that would be the exception to Parkinson's. In general, again, if we ask the right questions, we'll get good feedback and know that there's always room for improvement with Parkinson's. That's why we like to keep up on it. Some states only have 1 movement disorder specialist in the entire state. So there is an access to care issue for Parkinson's disease and movement disorder specialists. And one blessing out of COVID was the ability to do remote telemedicine visits. That way, my patients in El Paso, Texas, that are 9 hours away don't have to take off 3 days of work, and their caregivers or sons or daughters have to take off hotel rooms, several stops. They can just see me remotely. Now, The downside of that is you have to be willing to try, right? It is technology. It can be very hard, but it's a lot easier these days than it used to be, and people can walk you through it. But if that means you getting to see a movement disorder specialist, it's worth your effort. So don't forget about telemedicine as a bridge for the gap of access to care with movement disorder specialists. Let's say you don't have an MDS in your neck of the woods. Go to someone, go to your neurologist, but advocate for yourself. Ask questions about the new medicines that are out. Ask questions about what you've learned today. And if you're not getting the answers that you need, go find them. That's what is beautiful about our patients, is they are the biggest advocates for themselves these days. And I would even say that some of our patients know much more about Parkinson's disease than a lot of healthcare providers these days, because you're in it every day researching and looking, and that's to your benefit. So hopefully that answers your question, and hopefully you can get in more frequently, for those who ask, more frequently to your healthcare provider if possible, but just do the best you can.
Well, that was fantastic. This has been a fantastic program, great overview. And I want to thank you so much, Dr. Soileau. I want to thank Lucy and the Amneal team for giving us this chance to share this wonderful information with all of you. Thank you guys for all of your wonderful questions. And Dr. Soileau, we have this tradition, so we're going to follow through with tradition and invite everybody to share their wave of gratitude from all over the US. Thank you so much, everyone. Have a great day.
Bye, everyone.
Bye. Thank you.
Bye, thank you.